can welcome Mr. Reid, and again can I thank you for your service, your team and all of the frontline healthcare workers. I hope you can hear me, Mr. Reid. Thank you very much. I just want to put a number of questions to you. First of all, I have a lot to get through. I have 10 minutes, so if I know, I think you do appreciate that if the answers can be as succinct as possible, it helps us to put as many questions as we can. And the first one is in relation to the number of weekly tests which are being carried out. So you say that the HSE recorded the highest weekly test since April at 55,000, which I think we should welcome. But on the 26th of April, you said that there was confirmed plans to ramp up testing for COVID-19 to 100,000 tests a week. In fact, you said that it is expected that the 100,000 weekly test rate will be reached by the 3rd week in May. So first of all, can you give me the figure of what was the number of tests that were carried out in the 3rd week of May? And how is it that even still we're only at 55,000 and not at the 100,000 that you promised we would be at back on the 26th of April?
I'll be succinct. I'd appreciate I could say more. Specifically, what I did say was we are ramping up our capacity to have a capacity to test 100,000, and that's exactly what we did. The determination of what we test or how we approach testing or what gets serial testing, or there's 3 things drive what outturn is. One is the firstly, what is the kind of target approach of symptoms that we would be targeting for testing. Secondly would be obviously how much is spread in the community, and third will be determined by our approach on either serial or mass testing, which is determined by NPHET. But what I did commit, Deputy, there, I just want to be very clear, was that we would be ramping up the capacity to have 100,000, which we have done.
But sorry, I have your direct quote, Mr. Reid, and what you said was it is expected that the 100,000 weekly test rate will be reached, not the capacity to do it, but the actual numbers of tests. So whether or not you misspoke then, or whether or not we just haven't reached our figure. But given that we had a number of counties in semi-lockdown, still one in lockdown, given that we have higher levels of contraction, not just for meat plants but clusters in some parts of the country, I think people would expect us to be hitting higher targets. Like even the 55,000 is down from a high of 60,000. So all I'm saying is that I'm not judging you on my figures, because I don't think it would be irresponsible of politicians to make up figures. I'm quoting back to you, and this was reported widely in all of the newspapers, that the figure would be 100,000, and it was the number of tests that would be carried out.
Deputy, I'm being very clear. What we were asked to do and targeted by NPHET and overall government policy was to develop a capacity for 100,000, which we have done. We have a lab capacity which we've built up from 1 lab in the state for this COVID-19, the MVRL, to now 46 labs across the state. We've built capacity across our swabbing centres, and we've built a capacity across our contact tracers. The determination of what the volume is a function, Deputy, of what the cases being brought forward are, what the case determined of the testing is, and we, the HSE, are guided by what the approach in testing is and recommendations by NPHET based on the information and assessment they make. So,
Mr. Reid, I want to unpack, if I can, the median end-to-end turnaround time, which thankfully is down to 2.2, but just in terms of what that actually means. What is the difference between the average turnaround time for a community example as opposed to a sample in a hospital or some other setting, which I would imagine that the turnaround time will be much more rapid? So what's the average median turnaround time for a community sample?
Okay, and again, I will be brief, respecting your time, and I'm going to pass to Niamh Byrne. I will just make a very quick comment. Obviously, in a community hospital setting, it's rapid, it's much more quick turnaround. It's in the hospital. In most cases, it's less than a day, 0.08.
But do we know what the median turnaround time is for a community exam?
Yeah, I'll ask Ms Niamh Byrne maybe to give you the exact details on both.
Thank you, Deputy. In a hospital setting, there is no referral time. So when you see our statistics that we produce, we show a referral time. So that's the kind of time between a GP referral and someone actually showing up at a swabbing site. So the difference between community and hospital is that referral piece. No,
I know all of that, and I just need the actual answer to the question, which is the median end-to-end turnaround time for a community test. I understand it's different, that's why I made that point. I just need the figure, if you have the figure.
You would reduce it by 1 day, which is the referral time.
By 1 day. And does that include, is the 2.2 days inclusive of negative samples as well?
It's inclusive of negative and positive samples, yes.
Okay. And is there a difference between the turnaround time for positive samples and negative samples?
The only difference is that for positives, they go into contact tracing, whereas negatives don't go into contact tracing.
Okay, can I come back to you, Mr. Reid, in relation to another issue which is important, which is childcare for frontline healthcare workers? And can I put to you, and I won't give the name, but the content of an email I got from 2 frontline workers who work in a hospital in Galway, who had their children in a creche. They have 2 children. And essentially, because of the circumstances of the opening times of the creche, but also because of their times that they are due to go into work, because of the nature of their work, they both work on the front line in our health service. They are saying to me that they were left with no other option but to remove their children from paid childcare, that they have now no choice but to leave their children with their grandparents, which is not ideal. And they say, and I quote, "Why is there still no childcare options for frontline healthcare workers that actually work?" So can you, through me, communicate to them and others why it is the case that we still don't have a childcare solution that they themselves say works at this point in time?
Well, just Deputy, it would be unfair for me to look at that specific case because I don't have it, but I've no doubt of the authenticity of it. Just to say what we have done from a HSE's perspective from the very start of this, we have encouraged and directed local management to be as supportive as we possibly can. Firstly, if that's true, revised rosters where in cases that you have people we can accommodate in a different way. Secondly, we put out the real clear call to husbands, partners, spouses of healthcare workers to organisations and business that they would work at home and support our healthcare workers getting to work. We've put in place practices where if we can find alternative work for our workforce, we will do that, and we have done that on occasions. Obviously, healthcare workers and frontline workers are key for us, and we've shown the greatest flexibility we possibly can. And I've been very clear throughout this process from the very start of COVID that we will show and demonstrate the greatest flexibility we can. But obviously, there's a wider issue in terms of what government supports may or may be there at different stages. But we've been very clear to give what
I thank you for that response. But would you accept that from the perspective of many frontline healthcare workers, they still don't believe that there is a solution there that actually works for them? Would you agree that there is still a problem for many frontline healthcare workers in relation to childcare?
Many and our trade unions have represented that point to us throughout this, and that's why we are aiming to be as flexible as we possibly can.
And can I ask you, if the car parking, free car parking for frontline healthcare workers, is that still going to continue in the time ahead?
We continue to be familiar to some issue with Dublin City, and that has been well aired and publicly communicated on, and solution found to it for now. We've continued our process that we started at the start in terms of car parking facilities for healthcare workers. Okay,
and I want to just deal with one final issue, if I can, and it's I have a number of questions in relation to it, and it's screening services, Mr. Reid. And I think before I ask the question in relation to screening services, I completely understand that in terms of cancer, a diagnosis comes from going to a GP and being referred on, but we know that screening is very important in terms of detection, so it helps. So can I ask, first of all, what is the situation with cervical check, breast check and bowel screen in terms of the current capacity that those 3 screening services are operating on in comparison to, say, pre-COVID times? So my understanding is it the case that breast check still isn't up and running? Maybe some of the other ones are, but at what capacity are they currently at? And how do we ratchet up that capacity? What additional investments and supports, whether it's physical infrastructure or maybe more diagnostics in the community, whatever it is, how are we going to increase and ratchet that up in the time ahead? So do we have the figures in relation to what capacity they currently are operating at now in comparison to pre-COVID levels?
I just make 3 really quick comments and ask my colleague Dr. Henry to give some specifics. We launched a plan a few weeks ago now to ramp up our 4 cancer screening services. Firstly, to reassure the public and encourage the public, any people with symptoms and referrals from their GP should still come forward. Our services remained open during COVID and remain open now. Obviously, in terms of these services, our key focus is to protect the public and protect our staff, and some of the cancer screening programmes are more difficult in that regard, but we have launched a plan which steps all of them up. I'll just ask Dr. Cullinane to give some specifics.
Thank you, Deputy. Very briefly, as we announced before, has already up and running cervical screening programme resumed the first week of July with invitations in a phased incremental way, and we expect that all all invitations suspended during the up until that time will have been caught up by the end of October, and any cases that were delayed during 2020 will have been caught up by March 2021. And in terms of capacity there, in all 3 screening programmes, Deputy, it depends where the screening test is done, the nature of the test, and how it may facilitate transmission or not of COVID, and the dependencies. So the bowel screen programme, for example, the test is done at home, but the main dependency is the availability of colonoscopy. And colonoscopy is a procedure because of the infection prevention and control measures necessary in a COVID environment. There's a reduced capacity for us to deliver that service, but we're aiming to resume that screening programme at the end of September, as with breast. And the breast programme was supporting symptomatic breast care services during the first phase, if you like, of the pandemic, and it will be resuming at the end of September. And that requires 70% of the breast screening programmes, Deputy, are delivered through the mobile vans, and they require repurposing, again, to bring them into line with the infection prevention control measures required in the delivery of healthcare in a COVID environment.
Very much, Dr. Henry. Thank you, Deputy Cullinane. Could you provide a reply in writing? I think Deputy Cullinane had some additional questions.
Essentially, what capacity that they are currently operating at in comparison
If you
to
could reply in
pre-COVID.
writing
So the
to
actual numbers and figures and percentages, please, in writing, if that's possible.
Thanks.
We can provide you specific figures later, Deputy.
Sorry, I'm sorry, Dr. Henry.
I can't hear him, sorry.
I'm really sorry. I just have to move on to the next.
Okay.
I appreciate that you have it there. We might be able to come back to it at the end of the
If you
meeting.
can email them to myself today, that would be very helpful.
Thanks.
All of us.
To all members.